Hello, this is my first series on medical kind of concepts, and today we'll be talking about appendicitis. I'm planning to make a video series on gastrointestinal tract issues, and what better way to start than appendicitis, something that happens a lot, and I'm sure that every one of us have known someone that has been either had appendicitis or yeah. So let's start off with the first slide. So let's talk a bit about the appendix before we talk about appendicitis. So what is the appendix? It's basically a blind-ended tube at the proximal cecum, as we can see here and appreciate on the bottom. So that's what we call the appendix. And it's a hollow-ended tube. And as we can see that it's situated around here and it has blood supply through the appendiceal artery that it comes off the ileocolic artery, and it also has a venous supply, which isn't really indicated in the diagram, through the appendiceal vein. Both of these, artery and vein, are kind of encapsulated or covered by something called the mesoappendix. This is a fold of peritoneum or that covers this layer, and it's not really indicated in the diagram, but it should kind of cover around the appendix. What is the function of the appendix? So this one is, there's a lot of kind of theories on what the appendix does. Some people say it's a bit of a safe house for gut flora. So example, sometimes when we take antibiotics and we clear out a lot of our gut bacteria accidentally through using antibiotics, the appendix is thought to kind of have a reservoir of gut flora which can replenish the gut after ceasing antibiotics. Or if there's any disruption through stress or other mechanisms to the gut flora, the appendix is thought to kind of replenish the gut flora. But that's still a theory. Other theories says that it plays a role in the immune system. And it is actually indicated because we know that the appendix actually has quite a number of lymphoid follicles present in the appendix. Some people are a little bit more cynical and think it's just an embryological kind of organ that's just left behind. So we've talked about the blood supply, and now we should know that it's also innervated by a bunch of nerves, sympathetic and parasympathetic branches of the autonomic nervous system. And this is quite important when it comes to pain. We'll talk a little bit about that. All right. So like everything, life's not perfect in medicine. And in this case, appendix doesn't really sit perfectly just the way it does in every other person. It can sit in a bunch of different ways, and we can see that there are different locations of where the appendix would be. We can see the most common ones are the retrocecal, 64%, and the pelvic, 32%. Of course, these percentages are based on studies, can vary from place to place. All right, now we've talked about the appendix. What is appendicitis? Appendicitis, itis means inflammation. And so appendicitis is inflammation of the appendix. And what can cause inflammation of the appendix? It's listed right here, obstruction. So there's a number of causes for obstruction. Anything that obstructs the appendix can lead to inflammation of the appendix. The most common cause is lymphoid hyperplasia. This commonly occurs during adolescence and can also occur in response to viral infections in the body. A fecalith, so this is from stool, a little piece of stool can get and trap the actual appendix and cause it to become inflamed. Rare causes are appendiceal tumors and even intestinal infections such as pinworms. So the next one we're going to talk about is epidemiology. So who gets appendicitis? It's quite common. It's about 8% in the general population, a lifetime risk of getting it. And it happens around ages 10 to 19. So in the younger population, this could possibly due to that lymphoid hyperplasia, as we talked about previously. We know that males are more prone to getting appendicitis than females. So let's talk about what happens in appendicitis. It's an obstruction of the appendix. So why is this a problem? It's because mucus is unable, so like any other gut organ, appendix secretes a lot of mucus. It's unable to be cleared out. This leads to a lot of pressure, and this pressure starts building and starts to become inflamed. Also, in the gut, we have a lot of bacteria, and this is now unable to be cleared out. So it starts to multiply and can cause infections. And these gut usually tend to be gram-negative organisms, so you can expect to see things like E. coli and bacteroids. Now, the problem is that if it keeps on growing and the pressure keeps on building up, it can cause a lot of edema, a lot of fluid around the appendix, and it starts to compromise the blood supply. So the blood is unable to reach the organs of the appendix, and that causes problem. So it causes ischemia. So the walls start to become thin and weak, and now the appendix is now prone to rupture. Here below, we've seen an appendix rupture and release a lot of its contents into the peritoneal cavity. This is a cause of a medical attention. It's actually a medical emergency because now the patient has a risk of getting peritonitis, which is inflammation of the peritoneal cavity. Now, a substantial proportion of these patients can then develop sepsis as the bacteria goes into the bloodstream. Other complications of appendicitis can be a localized periappendiceal abscess, which means it's a localized collection of inflammation that can be a result of this appendicitis. All right, signs and symptoms. There's a difference between signs and symptoms. Symptoms is what's reported by the patient. Signs is what's picked up during examination. Let's talk about symptoms first. They usually complain of migrating periumbilical or right lower quadrant pain. So it starts off quite general in their general abdomen, periumbilical, and it starts to migrate towards their right lower quadrant. Why does that tend to be that case? What causes this migrating pain? It's all to do with their visceral and parietal peritoneum. So our gut organs are covered by the visceral peritoneum. This is supplied by autonomic nerves, as we discussed in the beginning, autonomic nerves of our nervous system. As you can see, it has a lot of supplies that kind of converges into these plexuses. They're supplied by a broad range of dermatomes. Therefore, the body is unable to kind of pinpoint exactly where the pain is. And thus, this area of the gut cannot be differentiated from other adjacent abdominal organs. Therefore, this first sort of pain tends to be quite diffuse and not localized. And this is due to the visceral peritoneum being supplied by autonomic or splenic nerves. Now, as the appendix gets more and more distended, it can start to press against the parietal, which is the outermost covering. This is now supplied by the somatic nerves, which are way more localized, and the patient can now report exactly the location of the pain. This point where it starts to be quite localized, and it's called the McBurney's point. You can see here's the anterior iliac, superior iliac spine, and the umbilicus, and it's about 1/3 of the way or 2/3 of the way from the umbilicus. So that's an important thing to remember. Other common symptoms are anorexia, nausea, vomiting, and fever as well. There is also some interesting signs that we'll also talk about. Once the appendix then ruptures as a complication, the patient can then develop rigidity, guarding, rebound tenderness, which is when the peritoneum, when the peritoneal cavity is involved. And this is a more alarming sign. So some extra signs. So these are some interesting signs. This is called the psoas sign, where hyperextension of the leg causes pain in the abdomen. The obturator sign is when internal rotation of the hips causes, again, pain. Rosving sign is an interesting sign where when you palpate on the opposite side, it causes pain in the right lower quadrant. So this is all due to where the appendix is located. Sower's sign is elicited usually when, if we go back, when we have our retrocecal appendix, performing this maneuver can cause pain due to the location of the appendix. The obturator sign is very commonly due to a pelvic appendix. So we can see here's the pelvic appendix. This is due to when you're performing internal rotation of the hips, it's involving the obturator internus muscle. And this muscle, when you're doing this maneuver, presses up against the appendix and elicits pain. This Rosving sign works on the principle that when you palpate in the opposite side, it places more pressure and it's more likely to possibly irritate the parietal peritoneum and cause pain. But there's a lot of theories on regarding what causes this, this sign. Investigation. So what do we do when we're suspecting appendicitis? Things would like to order bloods. We'd like to get a full blood count, a UEC, LFTs, and CRPs. Our full blood count will show elevated white blood cells, leukocytosis, showing signs of inflammation and possibly infection as well. UECs is to check for kidney function as a baseline. Liver function test could indicate other differential diagnosis, whether there is some other gastrointestinal causes causing this presentation. And CRP is an inflammatory marker, which is most likely to be elevated during this presentation. Other things is that we should do is we should usually get a urinalysis, a urine MCS, ruling other differential diagnoses such as a urinary tract infection. And beta HCG is very important, especially if they're female. So this is a pregnancy test because signs of ectopic pregnancies is an important differential to rule out when having this presentation and can be quite serious if missed. So very important to get beta HCG in the urine if they're female. Imaging tools, we can use ultrasound or CT with contrast CT scans. So CT scans are more accurate at picking up appendicitis, but they do have the tendency for greater radiation exposure. When a patient is female, younger population, or who are pregnant, we're most likely towards ultrasounds. So pregnant women and younger patients, we tend to lean towards ultrasound due to the lower radiation. Females, we also tend to favor using ultrasounds because we want to rule out a lot of the gynecological causes that could be also, it's a differential diagnosis that could also be causing this. So things like an ectopic pregnancy is something that's really important to ectopic pregnancies is also something that we should also rule out. So, and a CT scan could be more appropriate when the diagnosis is unclear, whether we're suspecting any other kind of gastrointestinal cause, or even with patients with higher BMI, where ultrasound might be very difficult to visualize. And sensitive signs in ultrasound is when you have over 6 millimeters of distension. It's quite characteristic. Other signs that you could note in an ultrasound is periappendiceal fluid, if there's any collections. CT scan could also show, so here we can definitely see the fecalith or that might be causing the obstruction. Other things that we could also notice on CT scans is if it's dilated, if there's any signs of inflammation such as fat stranding, which is commonly commented on CT reports, or even signs of abscess. So, scoring criteria. So you might have heard about the Alvarado score criteria, This is usually used in combination with ultrasound and laboratory findings and can be used to reduce the use of CT scans. So here's some features. This 1 to 4 is unlikely. 5 to 6 requires more observation. And 7 to 10 is likely needing surgical intervention. So that leads us to management. How do we manage appendicitis? So first, we'd like to control the pain. This could be through either paracetamol, anti-inflammatories, or opioids as well. So now to really definitive management is through removal of the appendix, usually through laparoscopic or laparotomy. So laparoscopic is using several small incisions and using a camera guided. This is shown to reduce a lot of complications and even reduces hospital stay after surgery as well. Laparotomy is a larger incision and may be appropriate when there's complications of appendicitis that's suspected. Laparoscopy using small incision in the camera has the added benefit where we can actually visualize other organs in that area to rule out differential diagnosis, such as gynecological causes. Usually antibiotics is used in combination with these management. Using IV antibiotics just by itself is considered first line in only a selected number of patients. While antibiotics by itself is shown to be quite effective in managing appendicitis, there is a higher rate of recurrence, and therefore it should be selected on a case-to-case basis. So that finishes off my first video on appendicitis. I plan to make further videos, so if you could comment or any other ideas on what I should cover next, that would be great. All right. Thank you.